Otitis media. Okay.
No.
Well, I think for the at-risk children, so bilateral, the younger children, what else is it?
Under 6 months.
Under 6 months, that's right. But otherwise, Emma Best, our colleague in Auckland, is the guru on this topic, and it's hold your nerve. And again, as you say, Bruce, it's about helping the patient and the patient's family, parents through an understanding of the process that it should settle down.
Oh, I have to say, I tend to err on the side of caution with Maori and Pacific kids, because they usually, and in fact, I say to my colleagues, I actually haven't seen a case of otitis media in a Chinese child or an Indian child. Now, my colleagues say they have, but I have yet to see one. I don't see a lot of kids, so that may be part of the problem. But Maori and Pacific kids are often quite sick anyway.
Yes.
And in terms of equity issues, I would err on the side of caution, and they're the ones who get mastoiditis and other things.
Yes.
So bilateral, the numbers need to treat, but the treatment benefit is only in terms of pain. Makes no difference to the long term. Makes no difference to the long term whether you give antibiotics or not. With kids with unilateral who are over the 6 months, I often say to the parents, again, is it a passive voice? We don't usually give antibiotics. We don't routinely give antibiotics to children with ear infections these days. What are your thoughts on that? And I've been amazed, actually. People will say, "No, how do you feel about that? How would you feel about not having it?" And they're often fine.
So what you would give paracetamol, Pamol?
Yep.
So one of my earliest memories is unilateral, what was presumably otitis media, and it was so painful.
As a child, yeah. So all the antibiotics are doing reducing the pain at day 2. That's what they do. That's when they talk about benefit. The numbers need to treat. And interesting, the otorrhea you get in the acute situation is actually a good. You get a better numbers needed to treat with that. Presumably the drum, you've got a bacterium in the drum and it's burst. So acute otorrhea is different from chronic otorrhea.
But what are you saying, that you should be treating?
No. Just that in a bilateral situation, that's probably a sign you've got a bacterial middle ear infection rather than.
Right.
Do people get viral? I mean, that's the other question for you, maybe. Do you get viral middle ear infections?
I think
Do we know?
I think so. Yeah.
And you occasionally see people. I saw a kid the other day, and she had some redness on the canal right by the eardrum, but the drum was completely clear. And
So it may actually just have been some cellulitis.
Yeah. And I just said to them, "Well, let's just try some drops, maybe, rather than giving oral antibiotics." You know, this was a young Pākehā kid who wasn't particularly sick, but
some topicals.
They do suggest children with recurrent infections you might want to give. Treat symptomatically, paracetamol. The back pocket scripts are quite interesting. The biggest reduction in antibiotics was in the otitis media study, a 75% reduction in antibiotic use if you give. So parents, I think again that's signalling that parents are keen not to give their kids antibiotics, and maybe with all the stuff that's going on, you know, about the microbiome and obesity and all this sort of stuff.
Also on Google as well. I think a lot of parents Google, do Dr. Google before they come in.
Yeah.
And on Google it says not to use antibiotics.
Oh, good.
Quite often.
Good. I'm with Dr. Google there.
It is interesting though, my nephew, who, while we were still in Auckland, we were living next door to, and he was solo child of 2 older professional neurotic parents. So, and
your relatives or your husband's?
No, mine. So it always seemed to be at non-medical parents. So he got a lot of ear infections, and I emailed Emma again. And I said, Emma, my nephew's had 5 ear infections this year as a 3-year-old or something. And she said, has he gone to daycare? And I said, yes. And she said, the average number of infections for a child in their first year at daycare is 6 respiratory tract infections. But the doctor was giving him amoxil each time. So I said to Kate, I'm not so sure about all this amoxil. And she went, yeah. And she's a little bit erring on the side of being a bit of a hippie, although she is vaccinated. But she said, but he gets better symptomatically. His mood improves so quickly. So that was her, so she was quite keen on the amoxil because he was so grouchy, and then he got the amoxil, and then he became manageable. So it is, I think, so I guess my point is, in these kids that are going to these daycares, it is a massive problem, the burden of disease.
Oh yeah, absolutely. My grandson went at 8 months and bam, 2 days he's off for 2 weeks, and gave it to me, and now I'm getting respiratory infections now.
Yeah.
But you know, they're virus factories.
Yeah.
Yeah, and Okay, so the doses, now there was some interesting stuff about dosage. The dose is quite high. They're suggesting 15 milligrams per kilogram per dose, so that's 45. Sometimes if there's severe infections, you give 30 milligrams per kilogram. And when I write these prescriptions, I usually write NB high dose, so the pharmacist doesn't think I'm doing something ridiculous. So it saves them a phone call, it saves me a phone call. So Dinner used to suggest actually high doses for everybody at one point, so I don't know quite why BPAC have stepped down.
Yeah, that's interesting actually. So at least the Auckland paediatricians do recommend, if you are going to be treating, to recommend to use the high doses, because remember that strep pneumoniae is one of the organisms that can cause bacterial otitis media, and over time the MIC, which is the minimum inhibitory concentration of the organism, of the bacteria that's needed to kill the organism. So as the MIC gets higher, that means that the minimum amount of antibiotic needed is higher in order to kill the organism. So with strep pneumo, the MICs have crept up. So some antibiotic resistance, it's sensitive, it's resistant, and it's black and white. With strep pneumoniae and penicillin, it's a stepwise progression. And so if that's completely sensitive and that's resistant, and you're somewhere here, that resistance can be overcome with a higher dose of amoxil by doubling the dose of amoxil. And so we don't know which children are colonised or infected with these intermediate susceptibility pneumo isolates, and so that's why it would be for all children, if they require amoxil, to give a decent dose of amoxil. So that was that and so I don't know if the South Island has less what we call penicillin non-susceptibility in pneumo, so that would be something worth for me to find out. I rather suspect that it's the same throughout the country.
And how do you decide what's a severe infection anyway? I mean,
no, so I would say,
sick as dogs.
So I would say if you're going to use amoxil in a child for this indication, you're wanting to cover strep pneumo, so you give the high dose.
You can understand.
Normally for less days rather than you do like 3 or
5 days, yeah, there's
same days.
Now. Yeah, the evidence, I'm going to talk about a randomised trial of Augmentin for 10 days, and the side effects were just horrendous. Like 30% of the group got diarrhea and nappy rash, you know, so it's that's probably the Augmentin rather than the 10 days, I think. But there was a benefit, there was like about a 10% difference. I'll show the slide. But the other thing I was going to say is that actually otitis media is slowly disappearing because of the immunisations.
Yes.
Barry Gribben's done some work on that, and I must admit I'm struggling now to show medical students a case of otitis media in the clinic, whereas there were days when every week I would see one. Now I'm struggling a bit. Yeah, so I'm noticing it clinically, which means something big's happening.
And that's with the strep pneumo. Yeah.
The pneumococcal, and that's been shown. The admissions for invasive illness are down quite a bit.
And I think with vaccinating the children, there is a knock-on effect that there are fewer admissions with invasive disease among adults as well. So it's actually, because it's not a cheap vaccine. I mean, Australia introduced it before we did, but obviously it does have economic as well as health benefits down the path.
I was going to ask you a question about I have heard that with methicillin-resistant staph, if you give massive doses of pure penicillin, you can overcome resistance. Is that true? But along the lines of what you were saying before?
No, that's an all or nothing one.
Is it? It is or isn't? Okay.
Yeah. So unless there's something that I never 100% trust my own knowledge, but no.
Your knowledge on these things is closer to God than mine. I was going to say about grumpy kids. Now that I've got a grandson, kids are grumpy all day. It's not as if they're only grumpy for a short period of time. So if you're the parent, you've got that relentlessness. You can understand them wanting the pain to go away and have a less grumpy kid. But this was the New England Journal article, Augmentin 5 for 10 days. How it got in the New England Journal of Medicine, I don't know. But anyway, 80% got a reduction of symptoms versus 90% in the Augmentin group. But 30% got diarrhea and nappy rash. I mean, God. for a condition that's not going to make any difference in long-term outcome. I mean, you know, so the answer is don't give Augmentin for, it's not one of the indications.
And maybe contributing to childhood obesity.
Yes. I think there are other regions in America, but...
Well, there's other reasons in New Zealand too, but apparently... You know.
Okay. So rather than talk about otitis externa or otitis CSOM, I like to talk about pus in the ear canal.
Yes.
Because that's how it hits us as GPs. So there's a couple of issues here. I think if my sort of view is that if it's an adult, it's probably an otitis externa. If it's a kid, it's probably a CSOM, it's pus coming from the middle ear. The only advantage of suction, and one of you was talking about suction here, is that you can probably see the perforation in a kid and figure that out for yourself. But suction doesn't help resolving the condition, even though ENT surgeons do use it most of the time. Half the trials didn't have suction, and most of us don't have access to good suction in primary care. So I divide the world up into otitis externa, which in my experience is often due to people using cotton buds. So you've got to say the old thing: nothing in your ear is smaller than your elbow.
Water. Yeah, a lot of people shower when they shower. They actually use the shower to try and clean their ears like they think it's syringing.
Oh, right.
But changing the pH in the ear, it's supposed to be 3.5 to 5.
Yep.
Changing that acidity to more pH 7 can actually give them fungal infections.
So in an adult, you should be able to see a clear drum, but you know, an inflamed canal, well, that's otitis externa. So I divide the universe up. Except in elderly, and I normally see it in Maori patients, just because that's the practice I've been working in for a long time. Older Maori patients will sometimes have pus coming out of their ears, and they'll have perforations which they've had from childhood and have gone right through, and the middle ear bones are pretty munched up, and they'll have a hearing problem. I remember Pat Isdale-Moore, when he used to go down to the East Coast. I mean, you know, pus coming out of your nose is okay, and everyone thought, well, pus coming out of your nose is okay, pus coming out of your ears is okay, but of course it's a whole different thing. And so it was sort of normalised down there for a long time. He used to have this ear bus. He'd go around. What's the place where the hospital is down there? Not Takaha. Tapuia. Yeah. So he used to go down there and do clinics and things. So he's still just alive, I think.
Oh, okay.
Unfortunately deaf and blind. Amazing. Sir Pat Isdale-Moore, amazing guy. So the standard treatment for either is antibiotics and steroids. And the big issue is, would it be better to give antibiotics alone or steroids alone? And you sent me that thing from Cochrane saying, really surprisingly, we can't, the evidence isn't conclusive either way. Topical, yeah. You don't use oral for pus coming out of your ears. Yeah. So
and also we get a lot of swabs, but I don't know that they actually help. And we have contemplated actually declining external swabs from external ears, because we now don't do sensitivity testing. We just report comments, and you know, if a fungus, maybe for otomycosis, that can be useful. So maybe swabs, you know, where that they have had a treatment trial, and at that point, yes. But of course, we never know in the laboratory because we get such poor clinical details. But I think, you know, you see someone with draining ear, I think a lot of it's automatic. You take a swab off. That isn't actually that useful, and it's better to give a trial of treatment. And we try and encourage the acidification actually, and I don't know, I'd be interested to hear in the textbooks it always says that oral toilet's the most important thing, so I always try and encourage them to go and see someone who can.
There's no trial evidence on that, is the problem.
The microscope as well, we can actually see the magnification, whether it is fungal or bacterial, so we can recommend to a GP what treatment is the best.
So how can you see that?
You can actually see the spores, so white candida spores or the black aspergillus. We can actually see it under because the magnification is like times 12.
How often do you see that compared to bacterial?
What, fungal infection?
Yeah.
More common than bacterial.
But you guys are seeing the worst cases.
You're seeing GP failed cases then?
A lot of people come self-direct.
So where are you working?
Ear Health in Oamaru.
Okay. And you've got a magnifier.
Zeiss.
Okay.
Yes.
Interested to know what the microbiology was compared to the visual. because this comes up in the next slide. So we know that acetic acid is not as good as antibiotics and steroids. And so my view is no swab, although the only time I have ever been very happy to take it, I had this middle-aged Pākehā guy come in with pus pouring out of his ear, and he had a cochlear implant. And I took a swab. He's the most unlikely guy to have, you know, anything, and he actually had a mastoiditis. And they were really worried he was going to lose his cochlear implant because that was the side it was on.
Right.
And he came back, in fact I missed it, he came back the next day and his face was swollen. That's when I thought, shipped him into Auckland. And
what was it?
It was a mastoiditis.
Oh, but what bug was it?
I think it was a pneumococcus, yeah. So at least they could get the antibiotics. So I was quite pleased about that.
That's good.
But I've had a bit of a fight with BPAC over this. So no oral antibiotics. Suction, nice if you have it, but it's not essential. Kids that, adults that. Now, if this was funded, that would probably be what you would use. Cochrane can't decide whether antibiotics or steroid. There are some trials and reviews going on, or both. That's not funded. Ciprofloxacin I is funded, so you have to dance delicately and make sure the patient, I've had patients where I've explained it very carefully what they should do. They still put it in their eye, not their ear. So you are slightly rorting the system, but it's in the benefit of the patient.
With people who we're assuming have got middle ear infection, but a lot of pus, sometimes I've said to GPs, have some oral antibiotics to try and bring that.
They would have pain though, wouldn't they, probably?
Yeah, or just like a GP called me the other day about this patient who every day had to change her bed linen because there was just pus. So I thought under those circumstances, I should try 5 days of an oral antibiotic, see if you can suppress whatever's going on. Is that acceptable?
We won't report you to the medical council for that.
That's the imavane I'm worried about.
No, wouldn't report you for that. I think that's quite clever, actually. I quite like.
I've got perforation as well. I disagree with the suction not needed, because I think if you've got a perforation and it's wet in there, that perforation is possibly not going to heal.
Yes.
It's wet. So you're saying about oral toilet, you know, it's where it's really important to sometimes suction the exudate.
So how do you actually physically suction? What happens?
Low grade suction with a camera.
So is it like a suction for when you have a trachea? Yeah. And
So my challenge would be, show me the trial evidence that makes a difference. Because it costs money and you can do damage. I mean, I've used suction and I've been poking, you know, your blood to cut, you know, if you're not careful, then suddenly you scrape the ear canal and, you know, it's not.
Yeah, but times 12 magnification, you're just doing it every day.
Yeah, I think.
Thousands of patients who get very.
And then once you've done it, say someone who's got yucky otitis externa and pus and stuff, once you've sucked it out, you don't pack it or anything, you just leave it?
We don't, no, we just get them to come back regularly, like maybe one or antibiotics as well, so just for regular and it's down on the antibiotics.
This is the hardest question the microbiologists get from the community. For us to actually try and come up with something helpful.
Anyway, this was BPAC's suggestion, so Vosol first. And does anybody heard of Clarquinol? Hands up if you've ever heard of it before.
Oh, I've heard of it.
Well, I have a particular interest in Clarquinol because when I was a teenager I got given it in Betnavate C, which you can still get actually. Although, does anybody use it? Does anyone use Betnavate C? Yeah. It's an antifungal. And I got a severe reaction to it. So the reason I remember it, because whenever I go to hospital I have to say I'm allergic to Clarquinol, and they always say, what's that, and can you spell it? So, you know.
It's got antibacterial activity
it does,
as well,
yeah,
too.
Yeah.
So it actually is not a bad choice.
Yeah. But BPAC was sort of trying to defend it on the ground that you've got lots of fungal infections. And I'm going to say, well, I don't think I've ever seen a fungal infection. And basically, people get better with topical antibiotics and steroids.
No, we do see otomycosis through the lab, and apparently it's exceedingly itchy for patients.
It can be, so a lot of people complain when they've got blocked ears for being really itchy as well, just because the wax is a general irritant.
But as a first choice, it seems an odd thing to give.
Yeah.
It's just because it's funded. This is the one that's funded, but here you're given two.
That's the.
And there is this issue, and it's not well documented, of middle ear toxicity from the gramicidin and framicidin. What's the?
Aminoglycoside.
Aminoglycoside. But the evidence isn't great that it causes inner ear harm.
So I asked an ENT surgeon, because if the eardrum is intact, that's fine.
Doesn't matter.
And I asked the ENT surgeon about giving these drops if the eardrum is not intact, and he said so long as it's got pus coming or gunk coming out, because it's sort of like a one-way stream. He said that's what in the Auckland ENT.
I think it's Australia, they use ciproxin.
Yes.
Yeah, ciproxin would be a better choice, although some people say that's got middle ear.
I think that's I've all got.
But anyway, we don't seem to have lots of people running around with deafness from having otitis, external pus in the eardrum. And do we need nystatin in there?
Well, that's, I guess, for the fungal.
Yeah.
So I recommend the Kinecomb just when there is fungal stuff isolated. Ah, right. Okay, that's...
The joke in primary care is Kinecomb's the drug you used to use when you didn't know what you were doing, but now it's the only choice.
Yes. Well, the Pseudomonas will be covered. Well, the acetic acid will help with Pseudomonas because it will just disinfect it. And also, I don't know if that low cortin's got activity against Pseudomonas. So I guess it's where it's Pseudomonas and it hasn't, the acetic acid hasn't helped. I guess that's the point. But the Kinecomb, that the antibiotics in that will have activity against Pseudomonas. But I think it's fair to swab if they've had a trial of therapy and it hasn't improved at all. Then at that point it's fair to swab. But we don't do sensitivity testing on it, and so but if we isolate Pseudomonas and I guess other things haven't worked, that's when you use the Cipro eye drops in the ear. So that's But
and I don't think that's going to get you in front of the medical council, the HDC.
No.
So
no, I think everyone, and in fact, it's all it's like in the guidelines and the pathways and stuff. I think
a lot of treatment as well. Sorry, a lot of treatment as well is ineffective because people aren't actually advised how to use it.
Yes.
A lot of medications are given without advice on administration. So just getting people to put it in the ears when they're completely over on one side, and to get the airlock out and make sure that sometimes we always find it's under medicated as well, because 2 drops in somebody's ear canal doesn't allow the fluid to get down to the base.
So would you, after you've cleaned it at someone's ear, would you perhaps put the first dose in the clinic?
If they've brought them with them.
Right.
From their home.
Okay.
Yeah.
Does your treatment change if you can't visualise the drug?
well, you can't. You're not an option in primary care.
Yeah.
You know, basically. And I have to say, well, I worked in Northern Canada. We used to admit we have 10 kids in hospital at any one time with pus coming out of their ears, and we just used to give them drops, and they all eventually got better. They were often malnourished. These were Native American kids. So why do you want to see what the drum looks like? You want to see if there's a perforation there when it's dry, because that's not a problem in kids, and the ENT surgeons sort of want to patch it by the time they're 8. It's sort of like a natural grommet, and actually it's no big deal. But it does seem to be a big deal if you take that perforation to adulthood, hence the elderly Maori patients who are now getting into their 70s and 80s. It's much less common that I'm seeing. So,
do they fix perforations?
Yeah, they take a little patch and put a thing across. Take a little bit of, I think it's a bit of skin from back here, just take a little skin graft and...
I didn't know that. I think I've had a perforation when I was a kid. No one's fixed that.
Is it fixed?
No.
Oh, you still got it?
It would have, oh, I see. So it heals. It's only the ones that don't.
But
heal
most of them
over.
heal up. By the time you get the eardrum dry, you've got an intact eardrum.
Or if you have one perforation that keeps perforating the same spot, so it just gets bigger and bigger and it stays there.
And then they would do.
So if you want to be a bit smarter, and you don't want to give the nystatin, because I find giving this just strikes me as awful. But then there's a part charge, so you can give soft. Did many people get Sofradex?
Now that low cortin's out of stock.
Oh, low cortin's out of stock.
It's been that way since about December. Yeah, I mean, Sofradex has the advantage too that you don't need to keep it in the fridge.
Oh, okay. Oh, that's interesting. That's a good.
All these things that we don't know.
But Sofradex, I mean, it is way more common now that there's no low cortin. And the part charge, I think for kids, or we do it for about $8 or $9, and for adults it's a bit more.
Okay. I suspect with the low cortin, it's probably the steroid that's working in that case. You know, but given my prejudice against Clark, when I'll. Okay, so that's. or necrotizing fasciitis, which actually Arlo alerted to me, but you'd say you'd never seen a case when you were doing ID stuff. So that's a fasciitis. Normally occurs in diabetics with severe pain. It's that old thing, if the patient's got severe pain, you have to rethink the diagnosis. Like a cellulitis with severe pain, either the patient's not got a great pain threshold or they've got a fasciitis. So you have to, again, err on the side of caution. You don't want to miss one of these things because, you know, you've got a dead patient fairly quickly, or large amounts of their body being amputated. So
they have to go to hospital for IV antibiotics.
Yep. Yeah. But as I say, this is going to be an adult, presumably, so it's not going to be your kid coming in.
And poorly controlled. I think it's poorly controlled diabetes for many years.
So the complications are cholesteatoma, which can be small or large and awful looking. It's worth going on YouTube if you've never seen a cholesteatoma. I always remember from medical school because they had an error in the handout. Instead of skin in the wrong place, the K was missing. It was sin in the wrong place, which we thought was actually quite intriguing to us as medical students, that you could have sin in the wrong place. So, so I always remember cholesteatoma. And I did pick up one in Canada, actually, and the child just had a little cyst on the eardrum. And I'd never seen one, so I sent the kid in because I didn't have a clue, and the ENT surgeon thought it was very clever referral, but I didn't realise it was a cholesteatoma. And then mastoiditis, of course, which is a slight problem of not giving antibiotics to everybody.
Yes, because, you know, occasionally they can cause brain abscesses.
We've been recently doing post-mesenteric extraction.
Oh, right, yeah.
We went up through up to the mastoid there and was picked up a few days later, and probably just at the time it can be fatal, obviously, as well.
So there are a few problems. COPD exacerbations. So technically you've got to have 2 of the 3 following symptoms to get a benefit from antibiotics. Increasing dyspnea, increasing the sputum volume, that's going to be a difficult one. So it's usually these things that, so it's normally in a patient who's otherwise stable and they start getting more symptoms. But
that in the community is very likely to be viral.
Yes. Yeah.
Origin.
Yeah, that's true. And I think the trouble is that one's always worried about pneumonia, isn't it, in these people. So, which antibiotics, when to use Augmentin? We've jumped pharyngitis, haven't we? Acute, so we're on page 5. So we've actually got, plus or minus clavulanic acid, amoxil, or kefaclor, or codrimoxazole, or doxycycline. BPAC doesn't mention erythromycin or roxy or codrimoxazole, but it seems like the common old normal antibiotics should work. Would you recommend Augmentin in any cases? If someone's growing a Moraxella on their sputum, I've got a patient who's had lots of course of antibiotics and she's now producing Moraxella. And she's a lovely 85-year-old Maori lady I'm hugely fond of, so I give her Augmentin.
Yeah, that is what we would recommend, but okay. I guess I'm just trying to remember.
I've got microbiology.
Yeah. I'm just trying to remember. I'm pretty sure Rupert, one of the ID physicians, was talking about a trial of COPD and steroids, but I can't remember the details. But of course the question again is how much of the bacteria contributing to an infective exacerbation of COPD in someone who's not so unwell that they need a chest x-ray or hospital admission, and who are we treating with giving the antibiotics to. And I think it's jolly difficult, and it would be interesting to have better diagnostics that were more widely available. So if you could have a sort of a point of care molecular diagnostic that you could do on, say, a throat swab. I mean, it's better to have a nasopharyngeal swab, or even the sputum, because these people do produce sputum. The problem is that that test will pick up pneumo and H flu and Moraxella regardless of whether it's actually causing the infection or not. But then if you also get an influenza A or a para-influenza, then you might be able to say, okay, let's have a backdoor prescription. And so, but because we don't have good diagnostics in this area, we do tend to end up treating with antibiotics.
Jeff Garrett has this thing, if your eosinophils are up, you probably should increase the steroids.
Yeah.
If your CRP's up, but I'm not sure quite how accepted that is. And of course you won't have a CRP till the end of the day, and you've got a bit of a problem if you see someone at 3 o'clock in the afternoon, and it's just easier to give them steroids and antibiotics.
Right. There is the procalcitonin as well, which is another inflammatory marker, which I think Waikato Hospital's got quite a lot of, but none of these markers are perfect, I guess, so it's always just collecting a little bit of information to sort of push you in one direction or another. I think that this is another difficult area for primary care. Okay,
which antibiotics, when to use Augmentin? So you think probably if they're growing Morixella, my lovely ladies?
Yes.
Fine? Okay.
Yeah.
I don't need to ask the 50-year medical student anymore.
No.
Role of steroids.
I'm a great believer in steroids.
If they're wheezy, yeah, me too. I was a bit upset with my gem with the harms, actually.
Yes.
That was an under 65-year-old, so you wonder what it does in terms of DVT and infections in the over 65. Okay, so antibiotics, this is the change. So COPD exacerbations, 500 milligrams TDS for 5 days. I think it was longer before.
Yeah.
Doxycycline, they're now going to this 200 milligrams stat.
Yeah.
Is that based on science? Or?
I think it's based on pharmacokinetics, but
yeah, because that's one of the problems in microbiology, isn't it? Sometimes you've got clinical situations, sometimes you've got what it does in the lab, and then you've got sort of drug levels and stuff. So you're dancing with different things.
It is about getting. It's a loading dose to get the levels up more quickly, and I think that that's good science.
Pneumonia, not ciprofloxacin. We probably should say something about Cipro. I've got a slide, I think, on that. Amoxil, 500 to 1 gram TDS. Would you give 1 gram to bigger people?
Yes. I think I'd give 1 gram if they tolerated it, because of those issues of the increasing MICs and pneumo.
If not improving after 48 hours. So with the Legionella, the way I do it, if there's Legionella in the region, I'm more... I mean, that hardly ever happens, but if somebody's got... I mean, there was Legionella in Howick for a while in Auckland. Yeah. So I was often giving a combination right to start with.
I think the problem with Legionella is I don't think we have data on what Legionella... So there's Legionnaire's disease, and then there's that Pontiac fever. And Pontiac fever is where you have a normal chest x-ray, but I think you get a bit of fever, and that's through to Legionella. And then Legionnaire's disease is where you're older, often a smoker, you've been exposed to the Legionella somehow, so you've been exposed to a high bacterial load, and you end up in hospital with moderate to severe pneumonia that can be life-threatening and can kill you. So that's the classical teaching of what Legionnaire's disease is. We don't really... So what we know in New Zealand... So traditionally, the diagnosis was culture and serology. And the culture is actually not bad, but it took a bit of time. And serology, which like most serology is kind of useless. You have to do the blood test when they first pitch up, and then get another blood test 3 to 4 weeks later and compare the serologies. And that almost never happens, and we all get exposed to Legionella, or because you're mucking around in the soil and it's in the water and da 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 da. And so many people have got background positive serology for Legionella, so that's why you need to have the acute and convalescent to see the change. But now there's more use of PCR, and David Murdoch in Christchurch did a big study around New Zealand of people being admitted to the hospitals with moderate to severe community-acquired pneumonia, and found, yes, there's Legionnaire's disease. But no one's looked at people with pneumonia in the community that's not bad enough to go to hospital to see whether there's any Legionnaire's disease in that. But from what we know so far about Legionnaire's disease is that it's an illness that's bad enough to require hospitalisation. So, because we sort of started doing some demand management restrictions on Legionnaire's serology, and I have people from the community phone and be a little bit grumpy, because I'd say, oh, the patient had worked with compost and now they've got a cough. And I'd say, well, that's kind of irrelevant. So the good thing is, though, that if you are treating for atypicals with erythromycin or Rulide or Doxy or azithromycin, that will cover Legionella. So that is the good thing. But I don't think in the person who is staying in the community because they're not so unwell as to require admission, I don't think that they need to have any specific testing for Legionella.
Isn't there a urine antigen you can
There
do?
is a urine antigen test, but that is, so there's all these different species, and that's for Legionella pneumophila serogroup 1, and so that's for only one incy, and we don't see that in NZ. We see Legionella longbeachii and Legionella mcdaddii, I think. So that test is quite good in parts of the world that sees a lot of that particular kind, but it's useless for us.
Oh, okay, because they do it in hospital here.
They used to. I think they've just stopped it actually because they recognise that our epidemiology is just so different from America and the UK.
Okay, so here you can use doxy twice a day. So you are in Guatemala here when you can use this. So
Okay, there we go.
yeah. So now you could just use roxithromycin as your first line, couldn't you, rather than amoxil? Why would you not do that? It's once a day. Like I worked in the kids' prison, and actually they have to have 3 guards when they give medicines to the kids. It's a big performance. So giving Fluclox 4 times a day was a big performance, as opposed to roxithromycin if they had a skin infection. So I started giving just once a day.
The rulide, or the roxithromycin, the issue for the chest is the H flu. That doesn't cover H flu very well.
Whereas amoxil does.
Where amoxil, well,
I thought it was a
amoxil doesn't always, because there's about 75% of H flu that produce beta-lactamates, I think. I always get quite nervous. I can remember it's 25% or 75%, but I'm pretty sure it's 75%.
I don't think many people in the audience will know that.
I know, but what if they, I should have my antibiotic, well, I could find it in the lunch break on the computer. But no, not all H flu will be covered by amoxil, and that's why there's the move towards augmentin. So...
You know too much.
No, I don't. I'm very ignorant, actually. But, you know, with community-acquired pneumonia, it's actually more likely to be strep pneumo, and it's smokers who end up with community-acquired pneumonia from H flu. Okay, let's talk pertussis. I think pertussis is very difficult. So as you know, pertussis is, it's highly infectious, and so if you have a pertussis case in a room like this and among the unimmune people, and we're all here, and you know, Bruce has been coughing and spluttering, I think, I can't actually quite remember the numbers.
More than 3 weeks, I'm not contagious.
Well, that's another contentious thing. But a lot of people will get the pertussis, so it is highly infectious. And the other problem is with pertussis is that the vaccine kind of doesn't work. Because we're old, well, I'm old enough to have got the whole cell vaccine. Bruce might have
missed out.
You may have been pre-vaccine.
That's right. I've had vaccine though.
I said to colleagues at work yesterday, I said, if you're old like me, you got natural mumps, and if you're really old like this other colleague, you had natural measles as well. So the whole cell vaccine that people of my generation got worked reasonably well, but they moved away from it because it actually made the babies kind of sick and floppy for a weekend, and it was quite unpleasant for the babies and their families. So they moved to an acellular vaccine, and it just actually doesn't work as well. And that's why you have to, I mean, I don't know the immunisation schedule off by heart, but you get 3 vaccines, don't you? And then when you're a teenager now, yeah, and then you get a booster then.
And then pregnancy.
And now pregnancy as well. So that's a problem, is that we don't have fantastic, and also we've traditionally not had very good vaccination coverage in New Zealand compared with some other similar kind of Western countries. So, and then we've got terrible diagnostics. So we've got so if someone presents with a classic, you know, inspiratory whoop and cough and and vomiting after coughing, that's easy, and then you can actually make the diagnosis, notify and treat on the basis of that classical signs and symptoms, and you don't have to do anything. But what we've got is we've got a community full of people, like most of us in the room, who are partially immune, and so we present atypically, and we present with cough. And so, you know, how, with all the young adults and other older adults and children in your community through winter, how do you differentiate the ones that have got pertussis and the ones who have just got a viral illness with a little bit of post-viral illness cough, and I think it's exceedingly difficult. And then the other thing, so then we say, think about pertussis in the adult or the teenager who's been coughing for 3 weeks. Well, once you've been coughing for 3 weeks, in theory, you're no longer infectious, although it's probably 4 weeks, depending on. And then also, is the treatment to treat the individual, or is the treatment to treat the public? And that's the whole other issue. And then, do you notify on clinical suspicion and then put that person in the situation that they can't go to work for several weeks? And so then do we do a and then it's not like a simple test, it's a nasopharyngeal swab, which is unpleasant and uncomfortable, and not all healthcare practitioners are experienced at doing it and want to do it. So there are all these barriers. There's barriers to diagnose because the PCR test is expensive. The swab is horrible. You wouldn't be doing it on everyone who comes in having had a week's cough, but actually if you want to make a difference to infectivity, that's actually the time. And then the alternative is just to give everyone with a cough 5 days of azithromycin, but we can't do that because we're talking about not overusing antibiotics. So my personal view is that it's an absolute nightmare and everyone should just get boosted with a vaccine every 5 years. We are trying to encourage the vaccination in the 3rd trimester of pregnancy, and what the laboratories have done is we put a comment out which goes out with the bloods, the antenatal bloods, saying, you know, vaccination for pertussis can save your baby's life or something like that, because people need to recognise that it's not necessarily about, so pertussis is a pain in the butt for adults, but it can damage and kill neonates. So I think it's an exceedingly difficult problem in our community, and we're having an outbreak, although the numbers actually are coming down.
Yeah, and I think if you want to get your head vaguely around it, I think what you said is fantastic. You might want to have a look at the guideline, at the health path.
Yeah.
Everyone know about the health pathways? You have to know them for your local region because the passwords are top secret because it's commercially sensitive. You're not allowed to give them to somebody from a different district. We actually announced one of our webinars and got a stiff little note from management that wasn't.
With the whooping cough with the pregnancy, you put that little note out for the mum to get vaccinated. What about the other parent?
Because the other parent doesn't do the hard work of having the baby, so it's the maternal antibodies.
Yeah.
Right.
Through the breast milk. So it's protecting the baby.
But they can pay for it.
Yes, yeah, and also they do the cocooning as well. So the other thing is the cocooning, where you do everyone that's going to be in touch with the baby, grandparents. So yes, but the main protection for the baby is those first 6 months of antibodies, and that's the time when they're at the biggest risk of having brain hemorrhages and death.
Influenza. I have to say, I mean, it's fairly rare in the community, influenza.
Well, the thing is with influenza is that it's a spectrum of disease, because
well, that's true.
People can be sort of relatively asymptomatic, can have just a cold, or can be horrendously sick. And so there are people out there who are wandering around. I think influenza is totally controversial though. You know, we're all told to get vaccines, which is good. I always get my vaccine. But vaccine science is not black and white. There are complexities with vaccine science as well. I think classic influenza for when you see patients is quite sudden onset of high fevers and really bad headaches, and that's classic for influenza. Testing in the community, there are sentinel surveillance. So my old GP in Auckland is a sentinel surveillance site, because obviously you don't want everyone tested, but you want to have an idea about what's circulating, and so they pick certain GP practices to collect data. But otherwise, if you're in the community and the person's not sick enough to go to the hospital, I don't think that there is a role for testing. But just because it's expensive and does it change management? And I guess that the oseltamivir thing is controversial, but it's, you know, the way that it might be sold by the drug company is it'll get you back to work earlier, and I'm not invalidating that, but the way we see it in the more hospital setting is, let's see if we can get this person out of ICU, or let's see if we can stop this person going to ICU. And the data aren't fantastic as far as I'm aware. I mean, I haven't read the studies in any depth. But I think influenza is part of being human. Get a vaccine if you can, and get lots of sleep, eat lots of vitamins. Imavane. No, don't you think our ancestors would have slept more in winter? Yeah. And then they probably
they didn't have lights. They had to sleep. Well, what do you do in a cave at night time?
Well, it's not good. Meditate.
Didn't have lights.
Meditate.
Well, the other funny thing is people used to have 2 periods of sleep at night. Yes. They'd wake up and about
and
1 or 2 o'clock,
go dancing, and then
or do something, and then go back to sleep again. Yeah. There's some funny stories about the Cochrane collaboration. Hounded Roche, because Roche published the positive studies. Okay, the downside of drug companies is they do 10 trials and publish the 2 most effective ones. And so the first trials, I remember reading of this, was people were literally getting better a day earlier. I thought, well, that's pretty damn good. When they got them all, it took them 5 years, and Roche sort of handed them a great pile of paper and said, you go and look at this. You know, it was really passive aggressive. And when they got the data, they actually found there was much more modest benefit from oseltamivir, which is the Tamiflu. And the nasal one may actually be slightly better.
Yeah.
But anyway, so the problem with influenza, these people look incredibly sick if they get to your office. Fortunately for you, most of them don't get there. They're too sick to come in. The commonest diagnosis you'll make is, Doc, I was so crook 3 weeks ago with the flu, and they did have the flu. I couldn't come in, and I was off for 10 days. In fact, I had to go and talk to the pharmacist when Tamiflu was made available through pharmacies. It's $90 or something, isn't it? It's quite expensive. And I said, well, look, I wouldn't want to be in a pharmacy trying to diagnose influenza, because I find it really hard. These people look super sick, and I'm thinking they've got meningococcal disease, and that's how the medical student died at Auckland about 8 years ago. Everyone thought he had influenza and he had meningococcal disease. He didn't have respiratory symptoms. I know the family didn't have respiratory symptoms, so if you would probably rule out influenza. You can get influenza without respiratory symptoms. You can get, you know, the muscle aches and the fevers, but if they don't have a bit of a cough or something, I would be flicking that patient to hospital. And my joke to the pharmacist was, if they can turn up and ask for Tamiflu, they haven't got influenza. I mean, that's the good news. If they can come in and want the drug, then they don't have influenza. They're that sick. And the last guy I saw, he was brought in by somebody else. He was a Pacific Island guy in his early 20s. And, you know, well, he may have just had a viral. He looked like he had influenza. I mean, of course, you don't know. And, you know, he had terrible rhinitis, and he was coughing, and he just didn't look quite that sick. He just didn't like there was just something, but he was able to talk to me. And so I gave him some pseudoephedrine, got some from the pharmacy downstairs, gave him some paracetamol and ibuprofen, and had a look at him a couple of hours later, and he looked way better. So I didn't send him in. But the problem is, you know, is that in primary care,
you don't always have that luxury to have the time.
You know, you got to watch this guy for a couple of hours and hope he doesn't die on your watch. You know, I mean, these people. And in the UK, they have this phone service where they go through these algorithms like the Healthline does here. And the 2 deaths they've had there have been from septicemia, because they're the ones that go under the radar. You know, they look like they've just got a bit of a cold and a bit of a fever and off colour, nothing severe. Because there's no, even though they've got meningococcal disease, they haven't got the headache. They've got the septicemia, and that's how people die. And one of them had actually seen a doctor in the UK and died. The other just died at home because the algorithm that was out of 10 million cases. That was one.
Yeah, that's pretty good.
2 deaths out of 10 million. So, but that's the one thing to think about is if this is influenza, what else could it be? Because boy, they look sick. But I don't often see it. I don't often see people that sick, but he was really, So influenza, vaccination. Well, the people in the vaccination area say that if they've got the right antigen, the vaccine works.
Yeah.
But of course, I don't know, half the time they've got the wrong antigen.
Last year, well, they guessed on the basis of, WHO does it on the basis of what circulated around last time. I think last year it was only about a 70% match. So we're hoping it's a better match this year. I haven't had mine yet. I need to do that.